Starting Point Coaching and Consulting presents Kairos Conversations, Connecting with Quality, the podcast. Kairos is Greek for the right time, the right season, the right opportunity. This podcast features healthcare quality professionals who share their journeys, their advice, their struggles, how they made that transition into a new and exciting role. My heart's desire is that you find this podcast to be inspirational to you as you make your own journey. Don't forget to share this podcast with your colleagues and friends and rate us on whichever podcast platform you listen to. Thank you for being here. Thank you for tuning in, everybody. Today I am joined by my guest, Dana Strauss. You may remember Dana from episode 30. If you haven't heard that episode, go back and listen to it. But Dana is a value-based care expert, physical therapist, and a fierce advocate for changing the way we do healthcare. So I'm super excited to bring Dana back onto the podcast so we can finish our conversation from the last time. Thank you for being here, Dana.
Oh, you're welcome, Brandy. Thanks for having me back.
I am super excited because our last conversation was so good that we couldn't get everything we wanted to say on one episode. For those who haven't yet listened to episode 30, I will just give you a little bit of a recap on some of the key takeaways from that episode. So Dana and I talked about value-based care, what it is, why you should even care about it. She did a really good job of explaining how clinicians can get involved in value-based care and how those who are passionate about healthcare quality, like I am, are naturals to move into value-based care. And today we're going to just continue that conversation because, well, for me, it's just so good. So I'm super excited, Dana.
Me too. Love it. My favorite things to talk about.
So from the last episode, one thing that we didn't dive into was the difference between primary and specialty care models. And on the last episode, you briefly mentioned primary care models. But when we think about primary care, we think about the physician. We think about going to our internal medicine doctor or our family medicine doctor, and that's the one who kind of guides the rest of our care. But is that what you're referring to when you are saying primary care model?
So that's a great question, and gives me a chance to frame this again in a way that hopefully will help that concept make a little bit more sense when we hear it, and maybe encourage listeners to think about it in a different way than they're used to hearing about it. I'm not even suggesting that those who are using the term and even the models that are being developed by CMS, Center for Medicare and Medicaid Services, that they're even thinking about therapists, but they will be. So the way I'll describe it a little bit further. So again, just to summarize the strategy of our largest payer in the country, in the United States, the Center for Medicare and Medicaid Services, have a goal of having all Medicare beneficiaries and the vast majority of Medicaid beneficiaries in a relationship with a provider accountable for the cost and quality of their care by 2030. And they mean business with this goal. One after another of their initiatives and their promises is being brought to life by the models that they're putting forth. And those models have focused over the last couple of years on what we're calling primary care. And so and not just primary care, but in addition to primary care models, longitudinal accountable care models. So the difference between the two is that a model just focused on primary care intends to put the dollars and the responsibility for quality in the hands of the primary care team. When it's an accountable care model, what they call it, or a total cost of care model, They're looking for not just the primary care provider teams, but providers of all types in a community. And that could include hospitals, it could include outpatient center specialists, anyone really that provides care and bills Medicare, bringing them all together to own accountability for cost and quality of care. In these models, there is a level of what they call financial risk that the Center for Medicare and Medicaid, and not just them, but of course, every payer copies what Medicare does because they genuinely need to. If Medicare's doing it in a model and a type of care and a framework is being pushed by the largest payer, we want providers essentially doing the same thing for all patients. So it's an evolution. We start with Medicare, Medicaid, and then the other payers come along. So when we are, putting these models together, the highest risk model, what they call risk, means you're taking all of the dollars, okay, from the payer, and you're saying to the responsible team, we'll call it a team, you're saying, okay, we're going to give you all of the dollars that you're going to use for the entire year for all care that your population is going to need to be paid for. And we're going to step away as the payer. We're going to just take responsibility off ourselves and we're going to put all of that responsibility on you. And now your job is to figure out, how do I provide the right care at the right time in the right place so that I can reduce the historic spend on my population while improving the quality of care. And the only way, as you can imagine, but I'll paint that picture, the only way to reduce spend is to improve quality. So let me take that one step further in painting this picture. If I am a primary care practice, I'm not going to define it yet. I'm going to get down to that level of granularity coming up. If I'm a primary care practice, imagine anyone that can be in this practice. We'll get to that. That practice has to do everything possible to keep patients from having to go to the hospital and then to other high cost settings of care. That's one of the large goals, to reduce historical spend. What does that mean? It means, number one, for very complex patients, you're doing evidence-based outreach to those who are complex to help them, first of all, have easy access to care when they need it, right? You're teaching them about their different conditions that they have to take care of themselves with. You're spending dollars in whatever ways it takes within what that program allows to keep that patient doing a better job with themselves and with the care team managing their health. Then you're also working on early detection, engaging proactively with everyone that you're responsible for so that they have their annual tests done. They come in and you have your colonoscopy test. Well, you have it every year so that when, God forbid, if or whatever, depending on your age, what the recommended cadence for that test is, you're having that test done so that you're able to catch anything happening that needs to be treated as early as possible. This is like quality 101, right? You're doing all of the things that are best suited to take care of patients. And what you're not doing is worrying about how many codes you're billing. That is taken outside of the picture. We're not worried about coding. We're worried about using the dollars proactively that we have to take care of these patients so that they will not need to use all of the historical dollars they've had to, because they end up in the hospital, they end up in post-acute settings, they go to specialists when the primary care team, okay, so here's where we get down to the granularity, the primary care team not having to worry about cranking out lots of visits for the purposes of billing. The team can do a better job managing what I call primary specialty care. I didn't name that myself. I've heard that by other clinicians in the past, and I think it is very applicable here. So what does that look like, right? You have a patient who comes in, let's say they have, let's use something orthopedic. They have low back pain, right? They have low back pain. Maybe they've had it before. No red flags where we would say this is an emergency, right? We're doing a good job screening. what can we do to manage that patient without needing to jump to the things that when you don't have much time with a patient, if you're a physician, right? You don't have time to talk about what kind of, that mobility, what we're going to walk for a week and potentially take anti-inflammatories, come back and see me in a week. We'll follow up with you in 3 days. Going through posture, all of the things that would be ideal in an evaluation that a primary care doc normally either doesn't have the time or skill set to do, gets punted off to MRIs, x-rays, orthopedists, right? Well, in a primary care team responsible for that patient's cost and quality of care, when you have a physical therapist as part of that team and the patient calls with low back pain without red flags, what do? They go right to the physical therapist and the primary care team. They skip the physician. Of course, if they should need the physician, the physical therapist walks next door in the same office and talks to the physician and they can coordinate care. But if you can see this picture I'm painting, another example, depression, anxiety. Patient is calling or even sees their physician. Primary complaint is depression or anxiety. You have your behavioral health clinician in the next door over. They immediately walk the patient over and the behavioral health clinician sees the patient rather than let's make a referral. Let's figure out who's in network. Let's try to encourage you to go. Oh, you don't have transportation. Oh, you have a difficult time embracing behavioral health care. All of these things that are barriers. So in my mind, primary care teams are teams of practitioners that are able to care for the primary, and I will say primary specialty needs of a population of patients for whom they're responsible. The example I used was the highest risk type, where all of the dollars are the responsibility of the primary care teams. And those models exist now. Let me stop there because I said a lot, and I'm sure there are things you may want to clarify before I move on.
From what I'm hearing you say, the primary care physician or practitioner gets a lump sum of dollars to care for this patient, and they can do whatever they feel is best within their clinical judgment for this patient to either help them get better or prevent something else from happening. But they have a set amount of dollars to use for the care of this patient.
That's correct. And what I didn't say before, but I think is important to say now, is it's the risk of the downside that forces a primary care practice to completely transform itself. Meaning, when you're faced with, I only have X number of dollars, and no matter what happens with my patient, I have to pay for that care. The patient goes to the ER, I will be paying for that. The patient has a 3-month stay in a skilled nursing facility, I will be paying for that. We didn't catch that colon cancer till it's stage 3, and now they need intensive, extensive chemotherapy, radiation surgery. I'm paying for that. So you imagine as a primary care team, let's start as a physician. As a physician, you understand you can't do this alone, right? So the physician may be the one that's originally targeted to get into this relationship with a payer. But once they decide or consider going into this type of payer arrangement, they go right to, if they're smart and they want to be successful, they go right to, what are all of the things we need to do in order to actually be successful, or we're going to owe this money out of our own pockets, right? Or they get like a downside insurance policy that helps with that, of course. But there is major financial risk. If I'm given $1 million, my population spends 1.25 million. That 0.25 million is coming out of my pocket, right?
Yeah, so that's what I was thinking. Like, what's the benefit to these providers if they don't do this right? They could go under. They're going to lose all this money.
Yep. And the benefit is that you have a tremendous opportunity, especially in, most especially, I'll say, in populations that are underserved, that haven't had proactive care. Imagine their historical spend, which and the historical spend of a region. There's different things used as benchmarks by payers. Imagine that historical spend has included no primary care physician. They use the ER for everything. No
Right.
proactive care, nothing that would constitute the kind of care that optimizes health, right? And minimizes emergent care. When you're paid your what they call capitated amount, or that proactive risk, all of those dollars that a patient has historically spent, when you're provided the historical dollars, your job is to reduce the spend. The only way to do that is by improving quality. Quality ends up being really, if you think about it, the most important component of being successful in these models. And what does that look like? Evidence-based practice, right? Always evidence-based practice, spending dollars on things that there's no billing code for, which is the largest flaw in how we pay primary care providers now. And by that, I'm going to lean into physicians there, because when we developed the system of paying physicians, the relative value unit system, we're not going to go into the full, computation here, but there's a value to each service that a physician provides, and any outpatient provider billing. There's a value to that service. Unfortunately, values are only added to services that are transactional. So having a 30-minute conversation to teach a patient, help them understand, someone with low health literacy, about what it means to manage diabetes on a day-to-day basis, there's no billing code for that, right? There's no billing code for coaching and training. Well, in this type of a practice, you can hire someone whose job it is, like a registered nurse or any clinician. You can just hire someone who works specifically with chronically ill patients to help them manage their condition, and spend as much time as you see fit, because you know that is time well spent in helping that patient prevent all of the negative downstream effects of their chronic illness. Does that make sense?
So that benefits the therapist to team up with these physicians and other practitioners to be part of the solution. And then the physician or the care team overall is going to spend less by being proactive with some of the ancillary services.
1000%, exactly on the money. And I love this conversation. I hope every therapist out there is listening and comes back to this. It is being done now, but by very and large, behavioral health clinicians have recognized this opportunity. It's not that they've done it on their own completely. It's as we, over the course of the Biden administration in particular, has had goals around elevating behavioral health, on bringing attention to the lack of access, right? The deficiency of providers, especially in certain cultures, attitudes towards behavioral health, especially in certain areas of the country where there are deserts of behavioral health providers. They've taken meaningful steps to expand the types of providers. And by they, I mean the Center for Medicare and Medicaid. They've they've provided new codes for different behavioral health providers in order to provide, primary care at the practice level. They've elevated the types of providers that in behavioral health can bill under general supervision, meaning they don't have to be directly in the practice. So they added licensed LPCs, licensed professional counselors, and LMFTs, licensed marriage and family therapists, and even substance abuse counselors. They've added those to the list of providers that can provide care out in the community, not in a provider's office. So they've taken the LCSW and the clinical psychologist, and they've made them primary providers of mental health care. They can bill some of the coordination codes that allow them to practice the very top of their license. So these primary care practices at risk have said, look, as a physician, I'm not good. This is not where I should be focusing my time. Ideally, I have these providers embedded in my practice. Now I can really develop behavioral health integration programs, right? We can do a remote program with a psychiatrist so that we can have that immediate access. They see me, the physician, maybe first, but then they're right next door at the behavioral health, right in my clinic. And then we get them right, if they need it, right to the psychiatrist if it's something that I can't manage as the physician, let's say, and I want to have that secondary consult, we go right on a telehealth consult. And by the way, the Center for Medicare and Medicaid and many other providers or payers have made it very easy now through remote access to allow any beneficiary to immediately get the help of a psychiatrist remotely. So behavioral health the arms have been wrapped around behavioral health providers, and primary care practices have said, come join us, be here, be with us on site. We're all going to work together, and together we can manage all of this upstream care, and we can therefore improve quality, reduce cost. PTs are not sitting at that table in any large degree. And by that, I mean, I hear and we see, all of us who pay attention on LinkedIn and other social channels, there's a lot of attention around primary care physical therapy. Mm-hmm. But the context of that is freestanding primary care practices that have physical therapists and other therapists in them. And that is a great thing. It's not enough. In other words, it's not allowing us access to where patients right now are seeking care primarily. So we want patients to come right to us. But the fact of the matter is, the more we put ownership on primary care teams, as the payers are trying to do, because we want everyone who is the right providers of primary care to work together on site. As we put that emphasis there and we put those dollars in primary care teams, those who are just focused on freestanding, quote, primary care physical therapy, they're like they're a step ahead of where we need to be giving attention to primary care teams to make a difference. And so that these teams and just the healthcare ecosystem can really tangibly see, oh, if I have a physical therapist on staff and someone comes in with shoulder pain, I don't have to write a prescription as a physical therapist or as a physician and say, go to this physical therapist down the street and because you have shoulder pain. Instead, I can say, hi, I have Dr. Wilkins, our physical therapist. She's right next door. You have shoulder pain. I am going to have you go right to her within the next 30 minutes. We're going to have you evaluated, or we'll, let's say, come back tomorrow. You're going to, whatever it is, depending on scheduling, and we're going to have her do a complete evaluation and consider the next steps in your treatment. It could be some of these things, but that's not my area of expertise. Now, what have we done? Rather than a panicked patient in pain going to a specialist when very likely, right, as long as there's no flags that this is some emergency or, that the patient critically needs to see another physician, we now have the physical therapist within 24 hours or maybe right then evaluating that patient. Oh, this is an old rotator cuff tear. You have, tendinosis, tendinitis. You have osteoarthritis. Coming to that likely differential physical therapy diagnosis, that is everything that patient needs at that time. So we're granting access to physical therapists by bringing them into these teams. And it's not that there's any barrier to doing this now. Any practice in full risk, all they need is to be shown, this is how we can support you. If you're going into these models, bring us into your practice and let us be part of your teams. We're not proactively going there. So I'm evangelizing this to therapists who are in those situations. Look, consider identifying who is applying to and entering these models, whether it's full risk or high risk models. We can get into that too, but proactively outreach and ask if you may join that team. Remember, we've got a lack of physicians and non-physician practitioners like NPs and PAs. We don't have enough of them to serve on these primary care teams as it is. So why not take the falls, the back pain, the shoulder pain, the safety, the gait disorders, all of the things that are best served by therapists, bring them into the practice, right? So that's the top of my soapbox on primary care and physical therapy, where I think we have to be to not be left behind.
Do you think this is going to be largely dictated by the State Practice Act? Because some therapy or some states allow therapists to use what we call direct access, and the patients come directly to them. And other states may not have that in play yet. Do you think this is going to be predicated on having that model in place, or is this more like a physician-owned practice where the therapist actually works for the physician?
So the interesting thing about full risk models, and I'm really glad you asked that question. In full risk models, physicians can have anyone in that practice working incident to if that's necessary, meaning I gave the example before about having like a registered nurse be a diabetes educator as an example. So you can hire registered nurses whose job it is to manage and work with patients, have their own appointments.
Mm-hmm.
They're not billing because we're not here in a fee for service situation, right? They're coming in, they're working with that registered nurse, with that patient as a registered nurse.
Mm-hmm.
They're working incident to the physician, not for billing purposes, but because clinically you're allowed to do that. You can have community health workers doing the same thing. Physical therapists and I don't pretend to have the practice acts down pat, but yes, where there is a limitation in a physical therapist's ability to work completely independently by having the physician right there, on site with you, you are getting over that hump automatically, right? You have the physician writing that order directly and you can provide that care. In most states, when you're on site, there are, and especially if you're under direct supervision, it's easier to meet those requirements. But I would say specifically for the full risk models, it's not even really a factor because the whole team itself is receiving a payment to the practice. So it doesn't really actually matter who's providing what care because the whole practice itself is participating in this model. And yes, attribution. So that means if I'm in a model, right now, attribution to a model is based on the physicians. So the physician, and that's something that down the line can be addressed. But right now, this is absolutely the way we have to work within the confines of these programs. Patients become attributed to these models because of either choosing voluntarily to be part of these models or because of historical claims to these physicians. So if I've been seeing Dr. Smith for 10 years and almost all of my claims for medical care or with this physician, I will be attributed to this model and this physician and practice will own my healthcare dollars and the responsibility for the quality of my care. Part of the reason that's that way is because of what is required in order to identify the risk of a population. So only
Mm-hmm.
physicians and APPs right now can provide medical diagnoses, right? And those medical diagnoses are used to establish the relative risk of one patient over another based upon their medical diagnoses. So these are some things that are just structurally based, part of how we identify and pay for care right now and
Mm-hmm.
how payers look at risk. Right now, those that can diagnose truly under the way the American Medical Association defines it are only physicians, nurse practitioners, physician assistants or physician associates, and clinical nurse specialists. We're not tackling that problem right now. We need them to do annual wellness visits because only they can bill for them. We need them to do evaluation and management visits because they're the only ones that can do that. Those are the things that determine attribution to these models. That doesn't mean we're practicing anything less than independently, especially when practices get really good at triaging on the phone. This is the complaint. Are there any red flags? The first person you're going to see is the physical therapist. That is in my mind, an independent practicing physical therapist working in a team-based environment with all the tools they need. And it goes the other direction. Patient comes in with low back pain, but you're doing a medical screening, as we should be with all patients, and their blood pressure is very high. Well, we're going to talk to them about that and immediately bring them and contact the physician who's right in the door next door or, around the little circle and say, Mrs. Smith has hypertension. I need you to see them promptly, right? Or the patient has severe anxiety. I need to get them not just being treated for back pain, but we need to address their anxiety, right? And the other thing that comes into play here, which I think is wonderful for the profession, is you are not, as a therapist, going to be able to address if there's one PT in a practice that has let's say it's 5 docs, 4,000 patients. I'm just throwing out a ballpark. you're not going to be able potentially to see every patient that has an issue that a physical therapist needs to manage longitudinally, but you will certainly have partners in the community that, should you need to refer, because that patient had, let's say you need someone to visit the home and you don't have as easy access to that, you're going to help the whole profession, right? And those in the community by the therapist identifying the need, the therapist connecting with the right community, PT, OT, ST, whatever it is, and directly connecting that patient and making sure they get in for that visit promptly. A lot of primary care team practices also have transportation vans because they want to have the easiest access possible. You can even have that access van take the patient right from the primary care practice team to the pelvic floor therapist 30 minutes away, for example. So you're getting that access. One of the barriers to care that we don't talk about a lot in therapy is access, right? There's so many,
100%.
right? And this impairs quality. I use pelvic floor example. Someone has urinary incontinence and a PT in pelvic floor is the right person to address that. And I'm not a pelvic floor therapist sitting in this primary care team. Their quality of life is so hampered by that issue. I now have the autonomy to make sure I'm getting that patient the care they need because I'm part of this primary care practice. I get excited, obviously, every time I talk about this because I see it on the wall. Everyone listening, be the therapist that takes the steps and gets into these models. You will not regret it.
Something that you said earlier that really struck me is how therapists at this point in time aren't even considering these models yet. We're not in the models like we need to be. And part of the reason may be, historically, we haven't practiced at the top of our license, right? We've kind of allowed ourselves to be devalued amongst the other healthcare professionals.
Mm-hmm.
And, now it's coming to a head and it's coming to the forefront that we have all of these skills and these things that we can do to serve the patient and to help improve this healthcare system. But the other professionals don't consider us for that type of thing because they haven't seen us in that light.
You got it.
So what do therapists do who are currently still at the bedside to help change that narrative?
I love that question. There are many layers I see to this problem and how we got here. Some of it has to do with the how we've structured payment for any care involving physical therapy outside of the outpatient setting. And I've spoken about this on social media a little bit on LinkedIn. Truly, if you talk to CFOs of hospitals and you have a conversation and no, you're in a vacuum and no one's listening, they will tell you the truth, which is we're a cost center. Therapists are cost centers, much like case managers, much like many, even nurses, although they are seen in a different light because of their extension in some ways to the physician.
Mm-hmm.
Therapists, we're not over this hump where we have loads and loads of physical therapists. And this is no criticism. Believe me, I don't want anyone listening to think that I'm criticizing bachelor degree therapists. Some of the best, most clinically astute therapists I know in outpatient have bachelor's degrees only. But where we've been in settings and therapists, in the acute care setting, where we've had these teams that have been together for decades sometimes, and they're mostly bachelors, even sometimes that pre-bachelors, even some of the master's degree therapists, and they've been practicing in this setting for years and years and years in a silo of providing bedside acute care or working in a skilled nursing facility. And they have been part of a narrative which is, the physician and the nurses are the key to the hospital. The physicians, by the way, bill for, as we know, for all of the care that they provide. They're not a cost center. Everybody else is, right?
Right.
The physicians and the nurses are closely collaborating day to day, minute to minute, and they understand what each other does. Not to say that nurses and doctors don't understand the value of a PT, but how we've ended up being used is to kind of fill in and I'm generalizing. I don't, I know lots of exceptions, but generally we've been used to fill in gaps and to meet requirements. So, things like patients coming in, ambulatory, they lay in bed, oops, now they can't walk, let's call the PT and get them out of bed. Or we just have a standard that the hospital has set where the only person that can get the patient out of bed is a physical therapist. We become in the minds of the ecosystem of hospitals as this, not a skilled provider. I use the outside. Let's go to pivot to home health, because I spent a lot of my career in home health. I loved home health. I loved individually helping every patient in whatever ways I could, coordinating care, using everything I could at the top of my license within the confines of Medicare Part A to do everything I could to help patients. So when I say I'm bringing this to light, I'm saying this unfortunately is the narrative. I would come into some houses and get, families yelling from the background, "Oh, mom, the lady that walks you around the house is here."
Oh my gosh, yeah, that.
We have a
Oh
problem.
my.
We have a problem, right? So this is the narrative in the minds of the public. Even I worked in acute rehab, which I loved. My first job out of school was acute inpatient rehab, seeing, for anyone listening, obviously, some of the most complex trauma and, newly diagnosed urgent rehab conditions. And even there, what would I get from patients? "Oh, did you graduate from high school yet?" And I'm doing highly skilled neuro rehab. The families, "Oh, did you graduate from high school? Oh, are you in college?" The idea that a physical therapist is this, like a technician. How did we get here? And
Right.
I really believe truly in my heart of hearts that we got here because we are not responsible for Medicare Part A organizations directly billing for care. We meet needs for those organizations to meet the requirements for them to bill care, but we are not billing for care. And unfortunately, that has led to this perception, and we've gotten therapists caught up in this perception. How many, I don't know, and I really should know this fact, it would be interesting, but what is the percentage of therapists that work in inpatient or Medicare Part A settings versus billing Medicare Part B? I'm going to guess it's pretty lopsided. So most therapists, let's say, or the majority, let's say above 50% as a guess, are working in settings where they're not responsible for billing for care. Their care decisions, their treatment choices have absolutely nothing or very little to do directly with the dollars that those settings see coming in on a monthly basis. Again, generalizing and simplifying, but I think the public, if you just imagine this generally listening to this, you know what I mean. We're not choosing CPT codes, right? Directly. Yes, there are situations where we do, but mostly the building is not seeing a difference in their reimbursement from Medicare Part A because of what we're doing. And where they did have that more directly was completely changed when we moved to PDPM and SNFs and PDGM and home health, right? Where we took away the intensity of therapy because that was being, unfortunately, it was incentivizing some bad actors too on the other side. But we've completely removed mostly removed the impact of the degree of therapy impacting the payment rate of the building itself, billing Med A. So I think so. So you said, how can a therapist at the bedside change this? Well, I guess it goes to a fundamental understanding that it is detrimentally impacting not only the profession, but without feeling that level of autonomy at the bedside to say, I am a consulting provider receiving a consult request by a physician, and I am a function as an independent, direct provider of care. And I am going to do my independent assessment as a consultant and
Mm-hmm.
give my evaluation and recommended treatment approach. Hopefully, that also includes some downstream recommendations that are accurate. What I see almost as a Bible is when I go into or work with, I'm not doing that in my present work, but when I've worked at my responsibility being helping therapists in the inpatient, especially acute care setting, recognize that there the reasons that they're writing on everyone's chart, patients unsafe to go home, skilled nursing facility recommended, or patient must discharge to SNF, they're taking away, thinking of just safety in such a simple format without evaluating every individual's complete situation and likelihood of benefiting in one setting versus another. We're just handicapping ourselves into the same narrative. So I encourage all therapists at any bedside, think independently, identify what is going on with this patient leading up to this hospitalization, and what can my recommendations and coordination with the rest of the team in the hospital, what am I empowered to do to make the most accurate recommendation and communication with that patient, their family or loved ones or caregivers, the physician, and the discharge planning decisions, so that the trajectory can change for that patient. If a patient's unsafe at home and they're falling, I'm going to use an example because it really is deep in my heart how much this, I know we have power here. Patient comes in because they're falling repeatedly. They're, let's say they're admitted for a UTI. So you're seeing them because they have a acute UTI, maybe even sepsis, but they've been falling regularly at home. They're living alone. The discharge to SNF or discharge to rehab or whatever, that recommendation is not solving any problems. You're kicking the can to another setting that is not incentivized as that setting to make sure that patient is going home to a different environment. The conversation that should be happening with the physical therapist, the physician, the social worker, or the discharge planner, the patient, the family, is the problem to solve here is you should not be home by yourself. Let's look at what the different options are, what opportunities we have to help you. What do you want? What are your goals? What are we looking at in terms of the options? And how can we facilitate the next best step so that you have a different end of your story rather than you go to a SNF, you go home and you're alone and you fall again because no matter what anyone does, you are not able to be home safely. We're empowered to do that.
And the thing is thinking outside the box because, just because the patient goes to a skilled nursing facility doesn't mean they have 24-hour supervision. So that is not solving the problem of this person needing someone with them. So that's not always the best setting, right? Maybe, the house needs to be set up in a way that the patient can be safe. Maybe there needs to be like those baby cams or nanny cams that you can watch the patient remotely and still talk to them because they're still cognitively intact and they'll listen to you even if they're not physically safe. Or maybe there's options for sitters or for day programs or for there's lots of different ways for us to think outside the box when we're making these recommendations for the next level of care, and then taking advantage of the setting that we're in, right? So I shouldn't be just if I'm the acute care therapist, and that's the setting that I worked in the majority of my career, if I'm an acute care therapist, I should not just be getting the patient up from the bed to the chair. My treatment should look different than if a nurse or a CNA or someone else came and saw that patient, right? I should be working on high level balance and distractions and obstacle negotiation and all of these things versus bed to chair therapy saw you.
You got it, Brenda. And I'm so glad you clarified that further. Such a great question and comment. As you're providing that like individualized skilled care at the acute setting and you're communicating with the patient, the family, the caregivers, and you're reaching out and you're really getting to the etiology of that weakness. Okay, if they just came in and unfortunately were left in bed for a week and now they're weak, well, and we know that they were really functioning independently and something fluky happened. Well, maybe a week or two. Unfortunately, it's hard for skilled nursing facilities sometimes struggle with only keeping people for a week or two, another topic for another day. But if there's really the ability, and we are clinicians whose job it is to make a rehab prognosis and diagnosis, right? So if the prognosis is, if the patient is given daily therapy for 1 to 2 weeks, they are likely to be able to return home to a setting where they can continue to progress to live independently. However, if that patient is someone who, through the course of comorbidities, through they have Parkinson's, they're a frail elder who, needs the interaction of others, whatever it may be, if the next step you're recommending is another inpatient setting, that because of the etiology of that safety problem that next setting is not going to be able to change the fact that even if they get the patient a little stronger, they're still going to need to go home with assistance or consider a different setting. Ask yourself then, why are you recommending a skilled nursing facility? If they can go home with home health and they have family, and you can work with the family for a couple of days, and you can coordinate with home health, and maybe they have a little bit additional assistance, maybe they qualify, they're in a state that has money follows the person, and they can qualify for intermittent assistance at home. Make the discharge recommendations make sense. Why are we shouldn't be recommending the next level of care? Because it's safe. That patient's safety may not be even remotely impacted by going to skilled nursing. And
Exactly.
remember, a skilled nursing facility is not incentivized to create the ideal discharge plan. Yes, they're required to as regulation, but their payment will not hinge on whether or not that patient goes home and oops, we didn't fix the problem that they're not safe. They fall again, go back in the hospital. The skilled nursing facility is not held accountable for that. No one is. If you can't make a patient safe, by make a patient, I mean, you're not able to address their safety concerns in a way that lets them go home independently, and they're going to be safe then, or you have the ability to project that, why are you sending them? And by the way, you don't send patients to skilled nursing to be independent. It's not even in the regulations. Skilled nursing does not have the authority for discharging to independent. They have the authority to continue to skill a patient day after day because that is medically necessary care that they have day-to-day treatment. As soon as the actual therapy can be provided intermittently, the regulations don't allow you to keep a patient in skilled nursing. So in other words, what problem are we solving is the question I put on therapists. Tell me what you think is going to happen with this frail elder who's falling repeatedly and you're sending them to a sniff. What are they going to change about that patient's trajectory?
Yeah, because the model of the skilled nursing facility in most cases is not such that they have the staffing ratios to even watch the patient to the extent that the therapists in the acute care setting think that they will. So they're still going to be sitting in a room with a call light by themselves. So that's not solving the problem.
They're also in a wheelchair all day, except when they're in therapy because of what? Quote, safety. We don't want them to get out of their chair because they might fall. Well, that means they're in bed or in a wheelchair 22 to 23 hours a day. Does that sound better than going home with home health and assistance where they can get up whenever they ask to get up? Not better. It's not better. It's not that there's not a need. There's plenty of need for skilled nursing facility care. It's that therapists are the critical component to helping discharge planning teams think really critically about why we are doing and recommending what we're doing. And are we heeding out the call of our profession, which is to actually impact this patient's life in a positive way, not kick the can because of, quote, safety, right?
There's so much we can unpack here because this problem or this even the solution goes very deep.
Oh yeah.
Right. There's not a one size fits all fix for this because we're largely bound by the regulations that we work under.
Mm-hmm. Correct.
And that's what gets people frustrated is because I want to provide good care. I want to make the recommendations that I feel are in my best clinical judgment, but I'm bound by the regulations and the payment models of this particular setting, right? Or this part of the continuum of care. And so I don't know if that's where, clinicians of all different kinds of disciplines have been burned in the past by the different payment models.
Yep.
To not know how value-based care is going to be different
Yep.
and how it's going to benefit the patient, but also these providers, these practitioners have to get paid too,
Mm-hmm.
right? So, yes, I want to help the patient, but I also have to feed my family.
You bet. You
And
bet.
how do I make this fit into a model that works for both, right? Because the governmental and insurance agencies are trying to reduce healthcare spending, reduce fraud, waste, abuse, all of that. And yet the practitioners who provide this clinical judgment come at a cost.
That's correct. That's 100% accurate. We could have a whole podcast. I mean, like a podcast in and of itself, just devoted to this one topic. I mean, we're just scratching the surface. I'll just say the one recommend to simplify when I've spoken to acute care therapists about this issue, and this is commonly what risk-based organizations will do to try to simplify some of what happened or remove the constraints that it puts on everyone when a therapist documents in the chart, patient unsafe discharge to skilled nursing facility. What we ask is to please consider documenting patient would benefit from ongoing rehabilitation, right? Discharge plan to include, and I'm just giving like a very rough example, but discharge should include ongoing physical and occupational therapy, something to that effect, instead of directly writing like discharge to skilled nursing facility, which means that automatically now the physician is not going to want to discharge that patient. The one that's responsible for what happens, the discharge signing physician, isn't going to want to send that patient home with home health and family support if the physical therapist put in there that the patient should be discharged to skilled nursing. Just as
Right.
one example, right? To just sort of just to ease it a little bit, because this is that to your point, this is so steeped in regulatory complication. Value-based care models start to chip, but they start to make us look at things critically, right? So let me go back. I know we're almost at time, but let me just go back quickly to our at-risk primary care model. PT, we have a PT, we have physician, we have behavioral health all together. That patient I just described who's falling at home, right, regularly,
Mm-hmm.
and is end up in the hospital, let's say they have a UTI. They're home and they're not safe. The person, the organization or the payer, let's say, the person or the organization now responsible for that patient's total cost of care, remember going back, Mr. Smith is part of my advanced primary care model that's taking full risk in Medicare, right? Let's
Mm-hmm.
say it's under the ACO REACH model. Well, remember how we said you can provide any upstream care? Well, if we are working, let's say, my practice, PT, behavioral health, physician, my practice is coordinating with the hospital down the street. My UTI patient, now the patient, my frail elder who had a UTI, is now sitting and getting ready for discharge. I now, right, as the advanced primary care team, can provide additional services, can go check on that patient every day if I want, can send my physical therapist to the home, can send a community health worker. We can have a team and this happens right now, community health worker, social worker that are just working, for example, with your most complex patients. The discharge planner, physical therapist, whatever, is coordinating with my social worker and community health worker. We're going to work with the home health agency and we're going to help to support additional care and get this all worked out and help the discharge planning team, because we, as the primary care practice, own responsibility for this patient's cost and quality. So we have every aligned incentive to help make sure, yes, is this the right plan? We can give the feedback, happens now, right? We can give the feedback back to the discharge planning team and say, oh, we started working with them on a new plan for home. We actually have the application in to this XYZ program. We have them connected. We just have these applications in. You can hand off to us. We are going to work on these things. And in the meantime, we're going to provide this additional care in the home while we get everything set up. This is the flexibility that comes with taking on accountability for a population. You own the cost and quality. And I'm going to use the word punished. You're punished as a primary care team if you make decisions that are not in the best interest of the patient. If quality goes down or spend goes up, you are responsible for that, and you are accountable to the payer to fix it, right?
That's a huge responsibility.
It is a big response. Oh, yes, it is. That's why that's a very advanced step for primary care teams to take. But accountable care organizations are doing things like that now. There you identify your patient is in the hospital. There's technological ways that accountable care organizations do that. The discharge planner or the physical therapist or whomever connects with the accountable care organization's care coordinator that's been working with this patient. You have a discussion about the home situation, about what you're working on, and about what plan you have to address these issues and why maybe or may not discharge to a skilled nursing or some other setting may or may not be in the best interest of the patient. And oh, by the way, this skilled nursing facility or these three or whatever are work with us very closely. So maybe we send the patient to this skilled nursing facility for a week or two. We work with our partner at that skilled nursing facility and we help smooth that discharge plan out and buy a little time. These are the kinds of things that are possible when you take any individual and have a primary care team or an accountable care organization be responsible for that patient's outcomes rather than there being a system which we have right now, which everyone is incentivized to keep treating and keep sending to the next site of care because they have no incentive for the outcome to be good. Other than, yes, there are some quality metrics that we have these small punishments given to different sites of care because of like 30-day outcomes, but there's no major responsibility on any inpatient site of care in traditional fee-for-service that incentivizes this kind of coordination, which I think I'd have a hard time anyone arguing with me that this kind of coordination and individualized patient decisions aren't the best thing for everyone. Wouldn't we want our care teams to care enough, because they're incentivized to, partly, to help work together so that the best outcome happens and the patient's goals are met? What could be better than that?
Yeah, it sounds like, this is the direction that we're heading for sure. And I think that, because this can get very technical, that people are going to need more and more information to really get comfortable with these types of models and this type of thinking. So I want you to remind people how they can connect with you.
So as of right now, what I am encouraging anyone who wants to learn more about this, and to Brandy's point, these are complex topics, but they don't start out complex. And there's a way to build this knowledge so that all of your listeners can be prepared and begin to learn the basics and build those skills to be a part of this movement, which I promise is inevitable. It's working now. We're just scratching the surface of it being something that everyone's comfortable with, but there's nowhere else to go but back to better quality, evidence-based practice and changing the incentives so that every individual is at the heart of every touch point of care. So I would love for anyone to please subscribe to my newsletter. It's called timelessautonomy.com, and I will be building out a membership, which will be essentially start with courses where you'll be able to take advantage of learning the basics through courses and then learning more specifics so that you as a clinician can build the knowledge, develop the expertise to be a part of this movement and find ways to pivot your career in ways that are almost impossible to imagine if you haven't stepped much into value-based care. I think this is the direction that is wide open for therapists to pivot, not dissimilar to quality, to Brandy's expertise. All value-based care does, as we talked about in the first episode, value-based care is just taking quality to the next step, right? To putting financial incentives, meaningful ones, on long-term quality outcomes for patients so that we can overall improve the way the healthcare system works and make the incentives about providing the right and best upstream care whenever possible. So again, timelessautonomy.com. I'm going to be beginning this membership in Q3. I post regularly on LinkedIn, little tidbits, and, be out watching for my membership offering to be coming up. I do have also an option for a pretty nominal price, either monthly or yearly, if you want to be a paid subscriber to the newsletter. I'll be giving out just a bonus here and there. So the material will be the same, but a bonus here and there. But then when I launch the membership, I will be giving a 50% discount to anyone that's been supporting the newsletter from now until then.
So if you're interested, if you're listening to this episode, again, go back and listen to the first part, which was episode number 30. But now is the time to get in. Now is the time to be on the forefront of this, to be the content expert, to be the thought leader in this value-based care space. And there's no one better to learn it from than to learn it from Dana. So I will put her LinkedIn handle in the show notes, as well as the link to her website or her newsletter, so that you can get involved and so that you can have some control over your career in a space that is not going anywhere. So thank you again for being here, Dana. I always enjoy talking with you.
Oh my, do I enjoy talking to you. Thank you so much for having me on, Brandy. You're an inspiration.
Thank you so much for listening to the show. It would mean a lot if you would share this episode with a friend or a colleague. I would be honored to encourage them in their journey too.